आप स्टार्ट कर सकती हो प्रोफेसर प्लीज.
Assalamu alaikum everyone. So today we are going to discuss about antiarrhythmic. Can you hear me, guys?
Yes, they can hear you.
Students? Okay. So the objectives of antiarrhythmics, by the end of the session, you should know the classification of antiarrhythmic drugs with the general pharmacology, uses, and the side effects of antiarrhythmic drugs, right? So to know what is arrhythmia, one should know what is a normal sinus rhythm, and to know so that you can understand the antiarrhythmic. So the normal sinus rhythm, to better understand it, we should know how and how is the propagation occurs, and what is the normal conduction pathway, right? So there's SA node in the right atrium. Okay, fine. In the right atrium, you have an SA node that generates the impulse. Okay. From there, the action potential travels down to the atria and to the AV node. From the AV node, it goes to the bundle of His, and the bundle of is divided into Purkinje fibers, right bundle and left bundle. So SA node generates the impulse and it delivers to the atria and the AV node. The AV node delivers the impulses to the Purkinje fibers, and from the Purkinje fibers it goes to the ventricles. Beside that, there is another action potential transmission occurs, that is between the myocardial cells, right, through the gap junctions. Okay, fine. To know how this conduction pathway occurs, you should know what is a normal, you can say, action potential, a cardiac action potential, right? So a transmembrane electrical gradient is maintained with the interior of cell negative with respect to outside of the cell, right? So likewise for other cells, cardiac muscles have a threshold, resting membrane potential, which is minus 90 millivolts. ठीक है जी, तो so this minus 90 millivolts is a resting membrane for cardiac cells, with the cells being negative, more negative interiorly, and positive outside, right? So you have certain ions extracellularly and intracellularly, sodium being the outside ion, calcium being the outside ion, whereas the potassium is the inside ion. So this gradient is maintained by certain ion channels, certain activating pumps such as sodium potassium pump and sodium calcium pump, and some leaky channels. Okay. This action potential, when the conduction occurs from SA node to AV and bundle of His and to the Purkinje fibers and to the ventricles, action potential generates. Action potential generates all these things, right? So action potential develops a wave segment on the ECGs, such as the P wave. Here we don't go in detail of the ECG, okay? But P waves will present the atrial depolarization, QRS complex, ventricular depolarization, and T wave will show ventricular repolarization, right? So the atrial repolarization is hidden in a QRS complex, ventricular depolarization, right? So it is not shown on ECG. So cardiac action potential has 5 phases. You can say phase 4 is the resting phase, which is minus 90 millivolts for the cardiac cell. And this phase, the cells remain unstimulated. Okay? The cells remain unstimulated. This corresponds to the cardiac cycle's diastole phase. Okay? There are 2 phases, diastolic phase and systolic phase. So this phase, the resting phase of the action potential, it corresponds with the diastolic phase of the cardiac cycle. Then you have a phase 0 in which the sodium channels gets open and the membrane starts to depolarize. The inward movement of sodium from outside to the inside occurs with the movement of potassium from the inside of cell to outside. And then you have phase 1, that is initial rapid repolarization, in which the sodium channels get closed, fast sodium channels. Then you have a plateau phase. This phase, a plateau means to maintain a balance, right? So this phase maintains a balance between the inward movement of calcium with the outward movement of potassium. Okay, it has the longest duration. The so it gets to
फिजा स्क्रीन शेयर होना बंद हो गई है आपकी.
मेरे पास आ रहा है होस्ट डिसेबल्ड पार्टिसिपेंट स्क्रीन शेयरिंग. वकास के पास तो शायद डिसेबल हुआ.
एक मिनट दोबारा कीजिए, दोबारा कर दें डॉक्टर.
जी
दोबारा कर दीजिए.
हुआ हुआ है, मेरे पास से कनेक्टेड है. वकास आपके पास से आ रहा है होस्ट डिसेबल्ड द पार्टिसिपेंट स्क्रीन शेयरिंग.
आप प्लीज दोबारा चेक करें, शेयर स्क्रीन पे क्लिक करें, कनेक्टेड होगा.
Yes, that's fine. Okay. So the phase 3 is repolarization phase, in which the potassium channels remain open. It allows the potassium to build outside of the cell, causing the cell to repolarize, right? And potassium channels finally close when membrane potential reaches certain level, that is certain threshold. A rapid review of the cardiac action potential as per the graphs. You can see there are different phases, with the phase 0 representing depolarization. In this phase, the sodium channel gets open and the sodium comes from outside to inside with the calcium. Phase 1, sodium channels gets closed. Phase 2 is the plateau phase. Calcium comes in to maintain a sustained balance between the potassium and calcium. Then you have a rapid phase, a rapid repolarization phase, in which the potassium channels remain open. That leads to more outward movement of potassium to attain a certain threshold. And between this, you will have from phase 1 to phase 4. This is the absolute refractory period, or you can say effective refractory period, in which a second action potential cannot be initiated. Okay, fine. So far, we have discussed the cardiac action potential. Cardiac action potential, the conduction pathway, we have recalled everything. Physiology, conduction pathway, the cardiac action potential, how it is generated, from where the impulse is generated, and how it is transferred, and how the graph is presented, ECG graph is presented. Now, what is arrhythmia? Arrhythmia, as it shows, let's break down the top. A, absence or abnormal rhythmia that relates something to rhythm. So arrhythmia is absence or abnormal rhythm, or break in regularity of a normal rhythm. This is, you can say, a simple definition for arrhythmia. So arrhythmia can be classified according to heart rate. It can be classified according to rhythm. It can be classified according to site of origin, either atrial arrhythmia or ventricular arrhythmia, or it can be classified according to complex presentation on ECG, like broad complex arrhythmia or narrow complex arrhythmia. I have classified it according to heart rate for your easiness. If the heart rate is less than 60, it is bradycardia. If the heart rate is more than 60, it is tachycardia, right? So if bradycardia is further divided into two groups: simple bradycardia or heart block, and tachycardia is divided on basis of QRS complex. If the QRS complex is narrow, that means it's less than 120 milliseconds. It it is a narrow complex. And if the QRS complex is more than 120, 120 is the QRS complex, you know, the block size, right? If it's less than 120, it is narrow QRS complex. If it's more than 120, it is a broad QRS complex. Narrow is further divided into three categories. It can be atrial flutter, fibrillation, supraventricular tachycardia, or sinus tachycardia. Or a broad complex is classified into two groups, such as ventricular tachycardia and ventricular fibrillation. There are certain causes for arrhythmia. It can result from disorders of impulse formation, right? If there is disorder in the impulse generation in node or AV node, or if there is an abnormality in the conduction pathway, right? The conduction from SA node to AV node, AV to bundle of his to Purkinje fiber, or both. If there is disorder of impulse formation, or if there is disorder, or there is break in continuity of conduction. There are certain other causes, such as changes in automaticity, right? Automaticity is like if heart generates impulse on its own, ठीक है, like एक एक्शन पोटेंशियल चल रहा है, उसके साथ साथ इन बिटवीन ऑफ वन एक्शन पोटेंशियल एक और फायरिंग हो एक्शन पोटेंशियल की, दैट इज चेंजेस इन ऑटोमेटिसिटी. Ectopic foci. Beside SA node, there is another foci. Re-entry tachycardias because of re-entry circuit, block of conduction pathway, block in conduction from SA to AV, AV to bundle office, abnormal conduction pathway, that is WPW syndrome, Wolff-Parkinson-White syndrome. That is accessory pathway, or you can say abnormal pathway. Electrolyte disturbance in certain drugs. Sometimes antiarrhythmics causes arrhythmia, such as flecainide. It causes arrhythmia. There are certain antipsychotics which causes arrhythmia. Beside that, you have hypoxic ischemic tissue can undergo a spontaneous depolarization and become an ectopic foci or ectopic pacemaker. Now, the antiarrhythmics have been classified on basis of channels and receptors, and it is denoted by Roman numericals, comprised on 4 groups: sodium channel blockers, beta blockers, potassium channel blockers, and miscellaneous group. This is a Vaughan Williams classification. Vaughan Williams is a scientist or a professor of Oxford University. He classified the antiarrhythmics into 4 groups back in 1960. So class 1 are the drugs that blocks the sodium channel, and it is divided into further 3 subcategories: 1A, 1B, and 1C, based on basis of duration of action. 1A, that acts for 1 to 10 seconds, 1B, less than 1 second, short duration of action, and 1C, longer duration of action for more than 10 seconds. Class 2 are the beta adrenoceptor blockers, atenolol, sotalol, propranolol. And class 3 is potassium channel blockers, which includes amiodarone. We are going to discuss amiodarone. Class 4 includes calcium channel antagonists, that includes the prototype verapamil and deltazim. I have made this chart. It's a summarized chart for antiarrhythmics. You can see on your extreme left the classes with mechanism of action and with their effects and so on. The class 1 are the sodium channel blockers. Sodium channel blockers, this slow, basically the sodium channel blockers, what they do, okay, what they do, they rises the threshold. Okay? When the sodium, what is the mechanism of action of sodium? It plays a role in depolarization. When you give a blocker, the sodium cannot enter into the cell. It abolishes the tachyarrhythmias which are caused by re-entry circuits, right? Beta blockers, they decreases the heart rate and conduction velocity. Can indirectly cause potassium and calcium conductance. Potassium channel blockers, they delay the repolarization. Potassium causes repolarization, rapid repolarization. So when you give a potassium channel blocker, it delay the repolarization. And you have calcium channel blockers in the last, that is the 4 categories. It slow the rate of rise in phase 4 of SA node, right? So class 1A agents it is a subclass of class 1, which is sodium channel blocker. Class 1A, they act on open activated sodium channels, right? Once the sodium channels are open, right, it acts on those channels. It slow down the phase depolarization, zero phase, which is a depolarization phase. So when it slow down the depolarization phase, it will lengthen the action potential duration as well as the effective refractory period. As I told you earlier, effective refractory period is a period from phase 0 to phase 4, like phase 0, 1, 2, 3, and 4. This is the absolute effective refractory period or absolute refractory period. It prolongs the QRS duration. Effective refractory period on ECG is represented as QRS complex, as a QRS duration, right? Then you have class 1A drugs uses. This is how it acts. It blocks the open activated sodium channels, and they lengthen the action potential duration and lengthen the effective refractory period. So what are the uses? They are used for ventricular arrhythmias and supraventricular arrhythmias. Quinidine is rarely used, but it can be used with other class 3 agents in the patients who have implantable defibrillator. IV procainamide is used for hemodynamically stable patients. Beside that, it is used in case of IV procainamide. It is used in case of Wolff-Parkinson-White syndrome. So class 1 includes two drugs, quinidine and procainamide. Procainamide is used for stable, hemodynamically stable ventricular tachycardia and for WPW syndrome, whereas quinidine is rarely used for supraventricular arrhythmias. These drugs produces toxicities such as cardiac depression. The cardiac depression, you can say hypotension, bradycardia, synchronism. Quinidine causes synchronism. Synchronism, like you will, the patient will suffer from like tinnitus, auditory hallucination, headache, and pain, auditory aura. GI upset, thrombocytopenia purpura, antimuscarinic effect, torsade de pointus, which is an arrhythmia, and hyperkalemia. Class 1B agents, they block the inactivated sodium channels, right? Class 1A block open activated channels, okay? So they prolong the phase 0, whereas this blocks the inactivated channel. Once they block the inactivated channel, it shorten the action potential duration and the effective refractory period. And they have the greater affinity for ischemic tissue that has more inactivated channels. So we're going to discuss lignocaine in this category, 1B agents. Okay, indications for lignocaine, cardiac arrest. Don't go into the dose of the drug, just remember the indications. Lignocaine for the cardiac arrest. Lignocaine can be given for stable wide complex tachycardia, okay, especially in presence of ischemia or acute myocardial infarction. With a good ejection fraction, lignocaine is not recommended in poor cardiac function. And watch for the signs of toxicity. 1B indications, atrial arrhythmias, ventricular arrhythmias, and ventricular tachycardia, ventricular arrhythmias, and acute myocardial infarction. It produces CNS stimulation, cardiac depression, allergic reactions, and hyperkalemia. Class 1C agent, class 1C agents, it includes flecainide, right? So, and they have a duration of action for more than 20 seconds. So, it blocks the sodium channels, strongly depress conduction in myocardium, it slows the phase 0 depolarization, and no effect on action potential duration, and no effect on QRS complex. So far, we have discussed the class 1 agents, which include sodium channel blocker, which is further divided into 3 categories, class 1A, 1B, 1C. 1A includes quinidine and procainamide, right? They blocks the open activated channel and they shorten the action potential. Whereas the class B includes lignocaine. It lengthens the action potential. Whereas class C, it has no effect on, lignocaine shortens the action potential, whereas class 1A lengthens the action potential. Uses of lignocaine, ventricular tachycardia, intractable SVT. Local anesthetic like CNS toxicity, 1C. we are discussing 1C toxicity, right? Flecainide is pro-arrhythmic, like it induces arrhythmia, hyperkalemia, and exacerbation of arrhythmias. Let's come to class 2A agents. Class 2A agents are beta blockers. They act on beta 1 receptors in the heart, and it includes propranolol, esmolol, atenolol, sotalol. And atenolol is indicated in case of supraventricular tachycardia. It's a second line after adenosine, digoxin, and diltiazem. It is given IV and can be repeated to a maximum dose of 15 milligram. Contraindications such as asthma, congestive cardiac failure, poor ejection fraction, heart blocks, calcium channel blockers, and cocaine use. Clinical uses, acute arrhythmias, supraventricular tachycardia, and prophylactic treatment in myocardial infarction patients. Toxicity of beta blockers. Beta blocker side effects such as bradycardia, it blocks the beta sympathetic receptors. So bradycardia, hypertension, hypoglycemia, hyperkalemia, bronchospasm, CNS effects such as seizure and coma. Then you have class 3 agents, potassium channel blockers. Potassium channel blockers. So the potassium channel blockers, they blocks the potassium channels, they prolong the repolarization, right? Once the potassium channels are blocked, there is no potassium entry or exit, right? So it will prolong the repolarization phase. As a result, it will prolong the action potential duration as well as the effective refractory period. It includes 2 prototype, ibutylide and sotalol, which is of beta blocker category. Potassium channel blockers, they are given in atrial flutter and atrial fibrillation, such as, for BCQ point of view, just remember the sodium channel blockers and the potassium channel blockers, they are given for atrial and ventricular tachycardias and arrhythmias, right? So toxicity of potassium channel blocker, it precedes the torsade de pointes. Torsade de pointes is a type of arrhythmia which is of polymorphic arrhythmogenic origin, right? And with a wide QRS complex presentation, and it causes sudden cardiac death, sinus bradycardia, and asthma. Amiodarone is a potassium channel blocker, which is the most important of the beta blocker. It is given for the arrhythmias which are refractory or which are failed to treatment to the other drugs, right? So clinical uses, rate control and converts the rhythm, cardiac arrest, and stable ventricular arrhythmias. Side effects such as hypotension, negative inotropic, it prolongs the QT interval, photosensitivity, thyroid disorder. Here you can see. Amiodarone, it produces the blue-gray discoloration of the skin as it gets absorbed into the skin with lipofuscin. It causes corneal microdeposits. It causes thyroid disorders. How? It impairs the thyroid releasing hormone response or TSH response to the TRH. It causes bradycardia and it prolongs the QT interval. It affects the lungs indirectly by causing interstitial pneumonitis, which further on leads to pulmonary fibrosis. The fourth category is calcium channel blockers. Calcium channel blockers, the fourth category is, hello? Guys, can you hear me?
Yes, Sudha.
Yes.
Okay. So calcium channel blockers, the calcium channel blockers, they are the blockers or the drugs that bind to the calcium channels, right? It includes the verapamil, diltiazem, nifedipine. It decreases the conduction velocity and prolong the repolarization, especially active at the AV node. Verapamil, it's given for narrow complex tachycardia. It terminates the supraventricular tachycardia. It is a rate controller in atrial fibrillation and flutter, but it is not given in WPW syndrome or high degree heart blocks, such as second or third degree heart blocks, right? And don't remember the dose. Toxicity such as negative inotropic, it produces negative inotropic effects, vasodilation, hypertension, bradycardia, and diltiazem has a less adverse effect comparative to verapamil. So the fifth category is miscellaneous. Some books say some book includes the miscellaneous, some books not, whereas Kadzing includes the miscellaneous. It includes 3 drugs: adenosine, potassium ions, and magnesium. So adenosine is a purine nucleoside. It acts on adenosine 1 receptors and open up the acetylcholine sensitive potassium channels. It inhibits the calcium entry, calcium inward current, so it suppresses the action potential, nodal action potential, AV nodal action potential, and it causes hyperpolarization of membrane, right? It causes increased outward movement of potassium, and it inhibits AV node more actively than SA node, and it increases the AV node refractory period. So adenosine, it interrupts the re-entry and aberrant pathway through AV nodal. It is used for diagnosis and treatment. It is a drug for narrow complex paroxysmal supraventricular tachycardia. Okay, remember, adenosine is for supraventricular tachycardia. Amiodarone covers all the arrhythmias. Sodium channel blocker and the potassium channel blocker are for ventricular and atrial arrhythmias, right? So toxicity, adenosine, flushing, hypertension, dyspnea, and transient chest pain. Contraindication, bronchospasm, drug-induced tachycardia, high degree, 2nd or 3rd degree AV nodal block. Then you have adenosine. For SVT, for supraventricular tachycardia, first is carotid massage, second is vagal maneuver, and then adenosine. Adenosine rapid IV push at a dose of 6 milligram, then 12 milligram, followed by another 12 milligram with a flush of 20 ml of normal saline, and then record the rhythm. Here you can see on your screen is ECG of a patient who was having supraventricular tachycardia, right? The narrow long QRS complex is regular. Then the dose of adenosine was given 6 milligram, 12 milligram, followed by another 12 milligram with a flush of normal saline, that is 20 ml. And then the normal sinus rhythm was recorded. Is it visible to everybody?
Yes, ma'am.
Okay. So, summary. Cardiac action potential has 5 phases. Arrhythmias may be classified by rate, rhythm, site of origin, complex presentation. Antiarrhythmics have 4 classes, 1, 2, 3, and 4, right? Was sodium channel blocker, potassium, calcium, and beta blockers. Sodium channel blockers are subdivided into 3 categories, 1A, 1B, 1C on basis of duration of action. 1B channels, they have greater affinity for ischemic tissue that has more inactivated channels. Amiodarone is most efficacious of all the antiarrhythmics. Diltiazem has less adverse effects. And for supraventricular tachycardia, first is carotid massage, second is vagal maneuver, third is adenosine. So now, okay, this is a video that will summarize the antiarrhythmic drugs. Let me know if you don't hear the audio.
Antiarrhythmic agents are drugs used to suppress.
Can you hear the audio?
Of the heart.
Yes, we can hear.
Yes.
They act to either interfere with the dynamics of cardiac action potentials by blocking a certain ion channel, or block the sympathetic effects of the autonomic nervous system on the heart to slow down heart rate. There are 5 classes of antiarrhythmic drugs. Class 1, sodium channel blockers. These drugs bind to and block the fast sodium channels that are responsible for the depolarizing phase in contractile myocytes. The result is a slower depolarization with a smaller amplitude. Slower influx of sodium results in a smaller flow of positive ions through gap junctions to adjacent cells. The adjacent cells take longer to reach the threshold required to generate a new action potential, ultimately resulting in a slower propagation of action potentials through the myocardium. This reduced conduction velocity helps to suppress formation of reentrant circuits, hence the use of these drugs for treating reentrant tachycardias. Class 1 agents are divided further into subclass 1A, 1B, and 1C. These subclasses differ in the strength of sodium channel blockage and in their effect on the duration of action potentials and the effective refractory period, the ERP, while subclass 1C has no effect on ERP, 1A prolongs and 1B shortens ERP, respectively. Changes in ERP may have different outcomes for different types of arrhythmias. A longer ERP generally reduces cardiac excitability, but prolonged repolarizations may increase the risk of torsade de pointe, a type of tachycardia caused by after depolarizations. Class 2, beta blockers. These drugs bind to beta-1 adrenergic receptors and block the sympathetic influences that act through these receptors. Sympathetic nerves release catecholamines, which act to increase SA node firing rate and cardiac conductibility, especially at the AV node. These activities may precipitate arrhythmias. Beta blockers suppress sympathetic effects, thereby decreasing heart rate and slowing down conduction through the AV node. The latter is particularly useful in treatment of tachycardias that originate upstream of the AV node, known as supraventricular tachycardias, or SVT. Note should be taken, however.
Anybody saying something?
Beta blockers may cause AV blocks. Class 3, potassium agents block the potassium channels responsible for the repolarizing phase. The result is a slowed repolarization, hence a prolonged duration of action potentials and refractory period. This reduces the heart's excitability and suppresses reentrant tachycardias. However, these drugs may also cause arrhythmias because slow repolarization is associated with longer and increased risk of torsade de pointe. Class 4, calcium channel blockers. These drugs block calcium channels that are responsible for depolarization in SA and AV nodal cells. Blocking these channels results in a lower sinus rate and slower conduction through the AV node. However, because calcium is also involved in cardiac myocyte contraction, these agents also reduce contractility of the heart and should not be used in case of systolic heart failures. Class 5 includes all drugs that act by other or unknown mechanisms.
Cardiac arrhythmias can be classified by site of origin. Sinus rhythms originate from the sinoatrial node or SA node. Atrial rhythms originate from the atria. Ventricular rhythms originate from the ventricles. Sinus rhythm is the normal rhythm of the heart set by its natural pacemaker in the SA node. In a healthy heart, the SA node fires 60 to 100 times per minute, resulting in the normal heart rate of 60 to 100 beats per minute. The most common variations of sinus rhythm include sinus bradycardia, when the SA node fires times per minute, resulting in a slower heartbeat of less than 60 beats per minute, and sinus tachycardia, when the SA node fires more than 100 times per minute, generating a faster heart rate of greater than 100 beats per minute. Sinus bradycardia and sinus tachycardia may be normal or clinical depending on the underlying cause. For example, sinus bradycardia is considered normal during sleep, and sinus tachycardia may be normal during physical exercises. Cardiac arrhythmias that originate from other parts of the atria are always clinical. The most common include atrial flutter, atrial fibrillation, and AV nodal reentrant tachycardia. These are forms of supraventricular tachycardia, or SVT. Atrial flutter, or A flutter, is caused by an electrical impulse that travels around in a localized self-perpetuating loop, most commonly located in the right atrium. This is called a reentrant pathway. For each cycle around the loop, there is one contraction of the atria. The atrial rate is regular and rapid, between 250 and 400 beats per minute. Ventricular rate, or heart rate, however, is slower, thanks to the refractory properties of the AV node. The AV node blocks part of atrial impulses from reaching the ventricles. In this example, only 1 out of every 3 atrial impulses makes its way to the ventricles. The ventricular rate is therefore 3 times slower than the atrial rate. This is an example of a 3-to-1 heart block. Ventricular rate in A flutter is usually regular, but it can also be irregular. On an ECG, atrial flutter is characterized by absence of normal P wave. Instead, flutter waves, or F waves, are present in sawtooth patterns. Atrial fibrillation is caused by multiple electrical impulses initiated randomly from many ectopic sites in and around the atria, commonly near the roots of pulmonary veins. These unsynchronized chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. The atrial rate during atrial fibrillation can be extremely high, but most of the electrical impulses do not pass through the AV node to the ventricles, again thanks to the refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate, or heart rate, is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. AV nodal reentrant tachycardia, or AVNRT, is caused by a small reentrant pathway that involves directly the AV node. Every time the impulse passes through the AV node, it is transmitted down to the ventricles. The atrial rate and ventricular rate are therefore identical. Heart rate is regular and fast, ranging from 150 to 250 beats per minute. Ventricular rhythms are the most dangerous. In fact, they are called lethal rhythms. Ventricular tachycardia, or VTAC, is most commonly caused by a single strong firing site or circuit in one of the ventricles. It usually